Hello everyone, this is Dr. Kavya. I am here today to discuss some most important and most repeated clinical case scenarios along with the diagnosis and few important points. Let's just brush them up for the ultra rapid revision. Before proceeding further, I'll just quickly request you, if you like the content, please like, share and subscribe. First case scenario: the patient is having gout, intellectual disability, self-mutilating behavior in a boy. The two important things in this question are: the first one is self-mutilating behavior, second one is in a boy. The most common characteristic feature of Lesch-Nyhan syndrome is self-mutilating behavior. So the diagnosis is Lesch-Nyhan syndrome. It is a X-linked recessive inheritance disorder which is due to the deficiency of HDPRT, that is hypoxanthine guanine phosphoribosyl transferase deficiency. Lesch-Nyhan syndrome is a defect in the purine salvage pathway. Generally, HEPRT converts hypoxanthine to IMP and guanine to GMP. When there is a deficiency of HEPRT, there will be increased activity of PRPP amidotransferase. So, there will be excess uric acid production. We can remember the main important symptoms of Lesch-Nyhan syndrome by the mnemonic HEPRT. H stands for hyperuricemia, G stands for gout, P stands for pissed off, like patient will be having aggression and self-mutilation. R stands for red or orange crystals in the urine. T stands for tense muscles, that is dystonia. The treatment of Lesch-Nyhan syndrome generally involves allopurinol and febuxostat. Coming to the second case scenario, there is a neonate with meconium ileus, recurrent pulmonary infections, nasal polyps, pancreatic insufficiency, infertility or subfertility. By the end of your question, most of them will recognize that this is a case of cystic fibrosis. Cystic fibrosis is an autosomal recessive disorder. It is due to the defect in the CFTR gene, which is located on chromosome 7 at the location of delta F508. The cystic fibrosis transmembrane conductance receptor, that is the CFTR gene, it encodes an ATP gated calcium channel which secretes calcium in the lungs and GI tract, and it reabsorbs calcium from the sweat glands. So the Phe508 deletion, which leads to formation of misfolded protein, and the improper protein trafficking and protein retention occurs in the rough endoplasmic reticulum. Usually the patients suffering with cystic fibrosis have clinical features such as recurrent pulmonary infections, most commonly due to Staphylococcus aureus during their childhood and Pseudomonas aeruginosa in the adulthood, and they also have allergic bronchopulmonary aspergillosis. Besides that, they do have chronic bronchitis and bronchiectasis followed by pancreatic insufficiency. Because of that, there will be malabsorption and steatoria. Fat soluble vitamin deficiencies occur, that is vitamin A, D, E, K deficiency occur in patients with cystic fibrosis. They also have biliary cirrhosis, liver disease, and the most characteristic feature is having meconium ileus in the newborns. The other notable clinical features are having nasal polyps and also nail clubbing. And increased chloride concentration in the pilocarpine-induced sweat test is the diagnostic of cystic fibrosis. Newborn screening is also done with immunoreactive trypsinogen. If there is an increase in immunoreactive trypsinogen, then it is a positive screening test for cystic fibrosis. The treatment of cystic fibrosis is mostly symptomatic. We have to do chest physiotherapy to drain out the secretions, and we can also give albuterol or aerosolized Dornase alpha, which is most commonly being used nowadays. And we can also give hypotonic saline. It facilitates the mucus clearance. Azithromycin is used as anti-inflammatory agent and also as antibiotic. We can give the enzyme replacement therapy for pancreatic insufficiency. Nowadays, there is a new intervention in the treatment of cystic fibrosis, that is a combination of lumacaftor or tezacaftor along with ivacaftor is used, because that lumacaftor and tezacaftor corrects the misfolded proteins, and the ivacaftor helps in opening of chloride channels, which causes the improved chloride transport. Third case scenario: the patient is having situs inversus, chronic ear infections, sinusitis, bronchiectasis, and infertility. The question it indirectly suggests that there is a problem with the basic ciliary mechanism. So the most common cause causing all these conditions is the primary ciliary dyskinesia or Cartagenous syndrome. It is an autosomal recessive disorder due to the dynein arm defect which leads to immotile cilia. As a result, there will be dysfunctional ciliated epithelium. The developmental abnormalities which are due to impaired migration and orientation leads to situs inversus, and hearing loss is due to dysfunctional eustachian tube cilia. Recurrent infections, that is most commonly pulmonary infections, and also sinusitis and ear infections. Bronchiectasis is also due to the impaired ciliary clearance of debris or pathogens in the lungs, and there will be infertility because the risk of ectopic pregnancy increases due to dysfunctional fallopian tube cilia, and there will be immotile spermatozoa which leads to infertility. Nasal nitric oxide test is used as a screening test. If there is a decrease in nasal nitric oxide, then it is positive for primary ciliary dyskinesia or cartagenous syndrome. The fourth case scenario, the patient has cephalid spots which are unilateral, the point to be noted, and along with polyastotic fibrous dysplasia, precocious puberty, and multiple endocrine abnormalities. When you see the term cephalid spots and they are unilateral, the one differential diagnosis one must always remember is McCune-Albright syndrome. McCune-Albright syndrome is due to GS protein activating mutation. Patient presents with unilateral cephalid spots which are especially with ragged edges and also has polyostotic fibrous dysplasia, that is, the bone is replaced by collagen and fibroblasts, and at least one endocrinopathy, which may be most commonly precocious puberty. The McCune-Albright syndrome is lethal if it occurs before fertilization because it affects all the cells, but the patient is survivable if the patient acquires this through mosaicism. Fifth case scenario is the patient is having arachnodactyly, that is long, slender and curved fingers, lens dislocation, that is specifically upwards and temporal, that is up and out, along with aortic dissection and hypoflexible joints. And the typical diagnosis here is Marfan syndrome. Marfan syndrome is an autosomal dominant connective tissue disorder which affects skeleton, heart and eyes. The FBN1 gene mutation occurs on the chromosome 15, which leads to defective fibrillin 1 protein. The fibrillin 1 is a glycoprotein which forms a sheath around the elastin. The findings which we can typically see in Marfan syndrome are the patient will be tall with long extremities, there will be chest wall deformities, that is pectus carinatum or pectus excavatum, hypermobile joints, long tapering fingers and toes, which is called as arachnodactyly, that is given in this question. And the typical presentation is cystic medial necrosis of aorta, aortic root aneurysm rupture or dissection, which is the most common cause of death in Marfan syndrome patients. They also have mitral valve prolapse and increased risk of spontaneous pneumothorax. Differentiating feature between Marfan's and homocystinuria is the lens dislocation. That is, the lens dislocation in Marfan's is upwards and outwards, whereas in homocystinuria it is downwards and inwards. Besides differences in the lens dislocation, the other differentiating features between Marfan's and homocystinuria are Marfan's is autosomal dominant, whereas homocystinuria is autosomal recessive. The intellectual ability of the Marfan's is normal, whereas in homocystinuria the intellectual disability is seen. And the cardiovascular defects seen in Marfan syndrome are aortic root dissection, which is most common, whereas in homocystinuria it is generally thrombosis or atherosclerosis. Coming to the sixth case scenario, patient presents with arachnodactyly, pectus deformity and lens dislocation. We have to note that the lens dislocation here is downwards. The major symptoms which lead our diagnosis towards homocystinuria are lens dislocation, that is downward, and the pectus deformity. There may be any other type of chest deformities in homocystinuria such as pectus carinatum, pectus excavatum, and arachnodactyly. Arachnodactyly is having a long, slender and curved fingers. It can be seen in Marfan syndrome, homocystinuria, and also Ehlers-Danlos syndrome. Homocystinuria is an autosomal recessive condition, and the causes of homocystinuria are multiple, and the main one is the cystathioin synthase deficiency, followed by decreased affinity of cystathioin synthase for pyridoxal phosphate, and the third methionine synthase deficiency, and the fourth methylene tetrahydrofolate reductase deficiency. These four enzyme deficiencies will cause homocystinuria. Let's quickly know the important clinical manifestations and how we can diagnose homocystinuria. It is mainly derived from the name itself. HOMOCY is the mnemonic for the symptoms of homocystinuria. H stands for increased homocysteine, O stands for osteoporosis, M stands for marfanoid habitus, O stands for ocular changes, that is downward and inward lens subluxation. C stands for cardiovascular effects such as thrombosis and atherosclerosis, which increase the tendency of stroke and MI. And Y stands for kyphosis. The patients also have intellectual disability, hypopigmented skin. You have to remember this like this. In Marfan syndrome, the lens dislocation will be up and out, whereas in homocystinuria it will be downward and inward. Marfan, FAN stands for fan. Where will be the fan? Up and it fans out. You just remember it like the lens will be up and fans out in Marfan syndrome. Seventh case scenario. There is a patient having elastic skin, hypermobility of joints, increased bleeding tendency. The first two clinical features, that is elastic skin and hypermobility of joints, is also seen in Marfan's and homocystinuria, whereas the third one is an important one here, that is increased bleeding tendency, which causes easy bruising. It is only seen in Ehlers-Danlos syndrome along with the first two symptoms. There are multiple types in Ehlers-Danlos syndrome with multiple inheritance and severity varies among them. It can be autosomal dominant or recessive. It may be associated with joint dislocation, berry and aortic aneurysms, and also organ rupture. The different types of Ehlers-Danlos syndrome are hypermobility type, which is the most common one, and the second is classical type, which involves joint and skin, whereas hypermobility type involves only joint instability, and the third one is a vascular type. It is most commonly present in fragile tissues including blood vessels, muscles, and organs that are prone to rupture. The mutations in type 3 procollagen leads to vascular type of Ehlers-Danlos syndrome. Type 5 collagen mutation is seen in the classical type of Ehlers-Danlos syndrome. Eighth case scenario. There is a patient having blue sclera, multiple fractures history, dental problems, and conductive hearing loss. Immediately, whenever you hear blue sclera and multiple fracture, our diagnosis should be directed towards osteogenesis imperfecta. Osteogenesis imperfecta is a genetic bone disorder. It is also called as brittle bone disease due to a variety of genetic defects, most commonly due to type 1 collagen defect. The most common inheritance of osteogenesis imperfecta is autosomal dominant. There will be decreased production of normal type 1 collagen, and the altered triple helix formation can be seen here. The manifestations of osteogenesis imperfecta are multiple fractures and bone deformities even after minimal trauma. Blue sclera, it is due to translucent connective tissue over the choroidal veins, and followed by opalescent teeth due to the lack of dentin. It is called as dentogenesis imperfecta. And the last one is conductive hearing loss due to the abnormal ossicles which are present in the patient. The patients are treated with bisphosphonates to decrease the fracture risk. You can remember it like patients can't bite, BITE. B stands for bones and multiple fractures. I stands for, that is eye, blue sclera. T stands for teeth, that is dental imperfections. E stands for ear, that is conductive hearing loss. And the ninth one, they have given only one, that is calf pseudohypertrophy. You can easily identify that calf pseudohypertrophy is most commonly due to muscular dystrophies, and in that also it is most commonly due to Duchenne muscular dystrophy than Becker's. Duchenne muscular dystrophy is an X-linked recessive disorder. It is most commonly due to frameshift mutation of dystrophin gene. And the next 10th case scenario, there is a slowly progressive muscle weakness in a boy. Becker's muscular dystrophy is an X-linked recessive disorder, but it is due to non-frameshift deletions in the dystrophin gene, whereas DMD, that is Duchenne muscular dystrophy, is due to frameshift deletions mutation, and this Becker's is due to non-frameshift deletions, and it is less severe than Duchenne muscular dystrophy. As a result, it is slowly progressive. The onset is usually seen in adolescence or in early adulthood. And the 11th case scenario is the child uses arms to stand up from the squatting position or sitting position. This sign is very important and it is called as Gower's sign. It is seen in Duchenne muscular dystrophy. As we have already discussed a little, Duchenne muscular dystrophy is an X-linked recessive disorder which is typically due to frameshift deletion or nonsense mutation. That is, the truncated or absent dystrophin protein will be present in these patients of Duchenne muscular dystrophy. There will be progressive myofiber damage which leads to weakness. First, the weakness begins usually in the pelvic girdle muscles and it progresses superiorly. The main characteristic clinical feature is there will be pseudohypertrophy of calf muscles due to fibrofatty replacement of the muscle. It is not due to the muscle hypertrophy. As a result, it is called as pseudohypertrophy because there will be accumulation of fibrofatty tissue. The patients typically have a gait called as waddling gait in Duchenne muscular dystrophy. The onset is before 5 years of age, and the most common cardiovascular defect seen in this Duchenne muscular dystrophy patients is they have dilated cardiomyopathy, which is the most common cause of death. Let's also know few important points about dystrophin gene because it is the largest protein coding human gene. There will be increased chance of spontaneous mutations in this gene because it is the largest gene. The dystrophin helps to anchor muscle fibers to the extracellular matrix, mainly in the skeletal and cardiac muscles. So, if there is a loss of dystrophin, which leads to myonecrosis, and there will be increased creatine kinase and aldolase, they can act as markers for diagnosing Duchenne muscular dystrophy. The genetic testing confirms the diagnosis. 12th case scenario. There is an infant with microcephaly, high-pitched cat-like cry, having intellectual disability. The cat-like cry is a characteristic feature of cri du chat syndrome. The cri du chat literally means cry of the cat. It is caused due to congenital deletion on short arm of chromosome 5, that is 5p deletion. The findings which we can see in cri du chat syndrome are microcephaly, intellectual disability, high-pitched crying, epicanthal folds, cardiac abnormalities, that is most commonly VSD. The mnemonic to remember the cardiac abnormality in cri du chat syndrome is I cry when I am very sad. 13th case scenario. They have given just simple one because you can easily identify this with this one clue, that is single palmar crease and intellectual disability. Definitely, I think you all know it is Down syndrome. Down syndrome is caused due to the trisomy of 21st chromosome. Down syndrome is the most common viable chromosomal disorder and most common cause of genetic intellectual disability. This is the most repeated question, that is what is the most common cause of genetic intellectual disability, that is Down syndrome. Let's quickly see what are the most common clinical manifestations of Down syndrome. They are intellectual disability, flat faces, prominent epicanthal folds, single palmar crease, incurved fifth finger, and gap between first and second toes called as sandal toe or sandal gap, and duodenal atresia, Hirschsprung disease, and atrial septal defect is the most common congenital heart disease in Down syndrome. And the other important point is brush wheel spots are seen at the periphery of the iris, and Down syndrome is associated with early onset Alzheimer's disease, and also there will be increased risk of umbilical hernia in Down syndrome babies. The first trimester ultrasound scan generally shows increased nuchal translucency and hyperplastic nasal bone in Down syndrome affected babies. 95% cases are due to meiotic non-disjunction, most commonly during meiosis 1, whereas the 4% of cases are due to unbalanced Robertsonian translocation, which typically occurs between chromosomes 14 and 21, and the rest 1% of cases are due to post-fertilization mitotic error. There are multiple ways of diagnosing Down syndrome. Mostly, we have to concentrate on double test, triple test, and the quadruple test. Double test and triple test and quadruple test are most commonly done during second trimester. Double test consists of alpha fetoprotein and HCG. Triple test consists of alpha fetoprotein, HCG, and also unconjugated estriol. You have to remember that it is not estradiol, it is estriol. And quadruple test contains alpha fetoprotein, HCG, unconjugated estriol plus inhibin A. The easy way to remember which of the following increases and which of the following decreases is just remember high up. H stands for HCG, I stands for inhibin. HCG and inhibin are up. It means that HCG and inhibin concentrations are increased, whereas the others concentrations are decreased. One last final thing is that whenever you remember Down syndrome, just remember 5 A's. First one is advanced maternal age, second is atresia, that is duodenal atresia, third is atrioventricular septal defect, fourth is Alzheimer's disease, that is early onset Alzheimer's disease, and the fifth one is AML in less than 5 years of age or ALL in more than 5 years of age. Coming to 14th case scenario, there is an infant or neonate with the cleft lip or cleft palate along with microcephaly or holoprosencephaly with polydactyly and cutis aplasia. All of this point to only one diagnosis, that is Patau's syndrome. Patau's syndrome is caused due to trisomy of 13th chromosome. The findings which we can see in Patau's syndrome are severe intellectual disability, rocker bottom foot, microophthalmia, microcephaly, cleft lip or cleft palate, holoprosencephaly, polydactyly and cutis aplasia. These are the most common and main indicators of Patau's syndrome, and the congenital heart disease is also present in Patau's syndrome along with the polycystic kidney disease and omphalocele. The average lifetime of the babies with Patau's syndrome is mostly 1 year of age. Death occurs by 1 year of age. And there is a defect in fusion of precaudal mesoderm which leads to midline defects in Patau's syndrome. 15th, there is an infant with microcephaly, rocker bottom foot, clenched hands and structural heart defect. When they give rocker bottom foot, your first differential diagnosis should be Edwards syndrome followed by Patau's syndrome. In Patau, rocker bottom foot is comparatively rare, whereas it is definitely present in Edwards syndrome. So let's quickly see some important points about Edwards syndrome. Edwards syndrome is due to trisomy 18. It is the second most common autosomal trisomy which results in live birth. First one is Down syndrome and second one is Edwards syndrome. Coming to clinical findings of trisomy 18, prominent occiput, rocker bottom feet, intellectual disability, non-distinction, clenched fist with overlapping fingers, low set ears, micrognathia, congenital heart diseases, that is most common is VSD, omphalocele, minor meningocele. The death usually occurs by the age of 1 in Edwards syndrome, as similar to Patau's syndrome. In this, every prenatal screening marker decreases, unlike Down syndrome. Okay, that's it for today. I hope you have learned something through this. Keep studying, don't get distracted. I'm definitely sure that you're gonna rock NeetPG 2023.